First, just want to welcome everyone to our third community forum and want to thank all of our speakers for being here with us for Caring in Community. I'm Carol Foote and will be your host today, or try to be. And we have tech support from Andy Weissman, also from LifePath in the background. Thank you so much for doing that, Andy. We'll be kicking off introductions shortly, but to do a little bit of Zoom housekeeping, we are recording this session so that it can be aired at a later date. So if you are not interested in having your face seen or your name or whatever level of privacy you may be interested in, you can shut down your camera and mute yourself, as you all are at the moment. But please, if you do want to speak, don't forget to unmute yourself with that button in the lower left-hand corner. And when either of those things have a red line through them, that means we cannot hear or see you. But when they are free of the red line, we can see or hear you. Also, you can change your view of who it is you're looking at, whether it's a speaker view, a gallery view. You can play with that up in the top right-hand corner. And at the end of the session, we will be opening up a breakout room with Sue. I don't know if you can see Sue. Sue, you want to wave? If anyone has any, topics to discuss privately, there will be that opportunity at the end of this session. So I'm just wondering if there are any questions at this point about any of that. We'll keep moving. So we did want to make sure that we recognize December 1st as World AIDS Day, and that today we're reminded that while significant progress has been made in the global battle against HIV and AIDS, there's still much more to be done. We would be remiss in this important acknowledgement if we did not mention the current pandemic. We invite you to participate in a moment of silence for those who have died as a result of AIDS, as a result of COVID-19, and for the hope we hold for advances in science, protection, and education. Let us be silent. Thank you all so much. Okay, so let us look to our panelists to introduce themselves, and we'd like you to share your name, your title, one thing maybe you want participants to come away with today. And let's start with Dean.
Okay, my name is Dean Lagrataria. I am the Protective Service Program Director at LifePath. I've been doing this for about 10 years, and I found PS to be a really good program. It's beneficial for elders and caregivers. The one thing I would like people to take away from this forum today is that Protective Service is a program like any other services in the community that helps people. Its goal is to lower risk and support elders in the community. Its focus is not punitive or restrictive, but rather restorative and supportive of self-determination. And that's the one thing from me, from Protective Services, hope you all take away from this.
Thank you. How about Yosefa? Can we continue with you?
You can continue with me. I thought I successfully turned off my snap phone for this, but I guess I didn't. I'm just gonna wait a second for it to stop ringing. Okay, I think we're good. Hi, I'm Yosefa Shearer. I'm the screening supervisor at Adult Protective Services. I've been working in this department at LifePath for about 5 years. And one of the things that I want all of us to take away from this conversation is how important it is to have a really expansive and creative idea about caregiving, and what those relationships are like, and the ways that they benefit the person providing care and the person receiving care, and the ways that that's complicated, and also can be really exciting and fulfilling.
Thank you. And Barbara.
Hi, my name is Barbara Nealon. I'm the Director of Social Service and Case Management for the Heywood Healthcare group, which is Heywood and Athol Hospital. I think this initiative regarding elder neglect, mistreatment, and protective services is a program that we've been able to enhance through our networking and one-to-one relationship, especially with the LifePath staff. So I look forward to the rest of the presentation with you today.
And Carol-Lynne.
Good afternoon. My name is Carolyn Papa. I am the practice leader of the emergency room at Heywood Hospital. I'm also the clinical champion of the elder mistreatment program that we've been in for the past year or the last 9 months. What I have come away with from after the last 9 months is the community links and the understanding of what we have for our elder in this community and what we still need to develop for the elders in this community, and the education that needs to go out to the caretakers and to the elders themselves who don't feel that the protective services are punitive, because that is one thing that we do find.
Thank you, Carolyn. So I do want to encourage any of the participants to unmute themselves should you have any questions along the way, or to use the chat to either write a message to everyone or to one of us, so that we can manage questions in that way if that's your preference. But we will move into more meat of this program. And what I'm going to ask is one person from Heywood and one person from LifePath to answer, describing the program. Who are the people who work there? What are their professional backgrounds and approaches to work? How does a person get connected to it? And what's the usual chronology of what happens? I thought that Carol-Lynne did a great job starting us off there. So whoever wants to take it, please do.
Carolyn, please do that. Carolyn.
Sorry, I didn't have you. I've been a nurse at the hospital for 35 years. I've been in this role as a practice leader for about 2 years. And about a year and a half ago, almost 2 years ago, Barbara Nieland got involved with EDC, and they reached out all across the country to place hospitals in a study to see how they could better assist them with community links to help the elders, and to see exactly how much mistreatment of elders we were missing. And I think when I first heard it, I thought, well, we don't have a lot of mistreatment of elders. And really, we have found that outside influences on the elders, we don't see as much. We've had a couple of cases of got in a fight with my son-in-law, my grandson stealing. But what we have found through the whole thing is that the elders do not know how to access services, and they need those services. And we as caretakers should be helping, assisting them do that. So what we did was all of our nurses in the ED, so our nurses are either 2-year grads or 4-year grads, all were trained to ask 3 questions of all of our patients 60 years and older. If the patient screened in yes to any of the 3 questions, then they filled out a 5-page form. And myself and one of the other nurses were the champions, and we were the resource for those other nurses if they had questions about whether they should do this or how to do that. Then what happened was all those forms came to me, and I found, and Barbara can tell you this too, our APS numbers, our filing of APS forms went through the roof this year, but not in a punitive way, but in a way for me to reach out to Dean and say, can you help hook this patient up with some services that they may need? And through all of that, I have discovered how many different people there are out in the community that I can refer these patients to, which we did not realize was there. And I take that and bring that back to the nurses. So when I'm teaching the nurses that no, yes, filling out the APS form is there and it's an extra piece of work, but in the long run, you're helping your patient. I also felt that we have developed a much more open relationship with social service in the emergency room in the past year. In the past, social service was something that went on upstairs in the inpatient units. It didn't happen in the outpatient unit so much in the ED. We just wanted to treat our patients and get them out of here. But we have discovered that social service and social workers can help us get those patients into the proper placements and not just home where they may not need or get the services that they need.
I think the other thing that we found is that sometimes our elders get in this perpetual revolving door. They keep coming back in through the emergency room, but you're not able to identify specifically what the issue at hand might be. So we've had to do a deeper dive into the social determinants of health to see if they have food, do they have transportation, are they able to get to their medical appointments. And that really, I think, again, has enhanced the opportunity for us as a healthcare provider to reach out into the community and say, hey, is there another provider out there that can help us out, or can we get a transportation voucher to get from point A to point B? But definitely this opportunity to work with LifePath in a way that, again, when Dean mentioned about punitive, and we want to see people looking at this as an enhancement to their day-to-day living. This is, there are resources, and there may not be the live-all, end-all out there, but together as a community, we should be able to come together to help our elders in need towards the later years of their lives. They shouldn't be struggling to eat and take care of themselves out there in the community. I now get off my soapbox, sorry.
So Carolyn mentioned there were 3 questions that are now being asked. What are those 3 questions?
Has anybody, I have to think off the top of my head because I'm not out there clinically doing it right now. Is anybody not hurting you? Has anybody not provided the care that you needed? Has anybody exploited you money-wise? And is anybody, I believe it is, hurting you? So, and not always do they answer, just because they may answer no, no, no to all those questions, but the staff in the emergency room may still screen them in. And they'll screen them in because they know that their nails are long, and they haven't washed their hair, and they're incontinent, and their clothes are dirty. They smell like dog or cat feces. Like something just isn't right. They're not getting the help and the care that they need. So they may say no, no, no to all those questions, but that doesn't mean we exclude them. Sometimes we still include them into further questioning and further screening of the patient.
We're also looking at financial exploitation. And when a patient comes into the emergency room, it's not the patient that we're actually treating. The care provider or family member that has come in with the patient. Again, our nurses, when in doubt, fill it out is their philosophy when it comes to reporting alleged abuse, neglect, and mistreatment. But they have almost a sixth sense down in our emergency room. If somebody's not, if their behavior is just a little off, and I'm not talking about the patient, I'm talking about the person that perhaps is with the patient, they're very, very perceptive, and they've had a good rule of thumb with their senses to report those incidences and let protective services do the investigation to see if there is truly anything there.
All right, so I'll talk a little bit about protective services. So like Barbara said, oftentimes they refer to us when there's a concern that needs a little more looking into than just maybe a referral to home care services from their department. So we do investigate abuse, exploitation, neglect, and self-neglect. Our assessment does delve a little more deeply into the root causes of the concerns, but it's not so much to establish that something has happened or there is a need. We have to kind of figure out why that need is there and what's lacking in order to actually put in some kind of service that would actually alleviate that concern. And so once we establish that there is a concern and we understand why it is, we develop a service plan, which is basically an intervention. We work with the elder to develop what intervention they want for their concern. It's a very much person-centered program where the client gets to decide what type of intervention occurs, and the intervention can utilize community-based solutions, their own strengths. It might resolve upon family or friends to help alleviate the situation in terms of protective services. But a lot of our cases do come from Athol Hospital. It's kind of where the process begins. And I do want to talk a little bit about how the work is done. We have 9 staff protective service workers at the agency, 3 supervisors and myself. We typically will have about 120 cases or so running at any particular time. We have a diverse staff. They have varying degrees of experience, education, and professional backgrounds. Some have been in the agency for 5 years or more. Some have just been there about 2 years. Some have worked in criminal justice, education, social work, counseling, crisis services, and domestic violence. And I would say that varied experience really is a strength of the department, because our clients also come from varied backgrounds, and they need different approaches about how they're reached out to and how they're talked to and how the case is assessed. And we assign workers based upon their strengths dealing with a particular client. So there might be some elders that might need a more nuanced approach. So we might assign a particular worker to that client, or somebody might need a little more of an aggressive approach. Somebody who's gonna be a little more stronger and kind of be more direct. So depending on what the elder needs, again, it's very client-centered. We really look at a case-by-case basis, and all the workers approach the work with the elder at the center and not around the elder, because that's the problem. A lot of times programs get bogged down in is they do a lot of work around the elder without thinking about the elder in the center. And as far as getting connected to the services, like Barbara said, it starts with that referral to protective services, and it's either done online or by phone. And when I'm done talking, I can put the number and the link in the chat box so everybody needs it. There's no charge for the program, and if a report indicates there's risk, it might be assigned to a protective service worker once it's filed. I could turn it over to Yosefa, who wanted to talk about the chronology of what happens once a referral is made.
Hi, thanks. Yeah, I just wanted to share that reports come in from all kinds of sources. Really, anyone that has contact with an older adult in community can make a report, and sometimes should make a report, and does. And so these are friends and neighbors and family members. Sometimes these are family members and friends that that live somewhere else and don't have direct contact and are worried and aren't quite sure what else to do. And sometimes it's from professionals that have a very specific clinical perspective about what's happening in their concern, and have eyes on our care provider, and have a much more direct relationship to the concern that they're expressing to us. And all of those reports are good reports and necessary reports that we want to talk to you about. We'll talk a little bit more about this later, but I also just want to say, because it's on my mind, I don't want to forget that everyone who is interested and concerned should know that I'm available, and many, certainly all the supervisors are available to just sort of talk through and do an informal consultation about what you're seeing or what you're concerned about, really any time. And that call does not have to end with a report. You won't sort of find yourself cornered in a situation where, well, I called Protective Services. I'm not sure if it requires a report. I'm not sure if I'm comfortable taking that step. So I want everyone to know that you can call and talk to us, and that doesn't necessarily mean that a report needs to follow or should follow. The chronology sort of like telescopes. So the period from when you would consult and make a report, and we would determine whether or not we were going to take a closer look at it, is very short. The maximum that time period is usually about 48 hours that we would sit with a report and try to figure out what we would do next. It is often much, much shorter than that. It's usually just a few hours. And then there's a period of a month or less where if we've assigned it to one of our protective services workers to take a closer look, that they're meeting the older adult, they're taking a look at what the needs are, what the concerns are, what the supports are, what everybody's goals are, and trying to determine, like, do we have an incidence here of abuse or neglect or exploitation or self-neglect that needs some further intervention? And if that's the case, the longest, sort of the most extensive time is spent in that next phase, where a protective services worker and their supervisor team says, yes, there's a concern here. The technical term we use is that we substantiate that concern. And then that moves on to a different sort of relationship that's more like a traditional social worker case manager role, not in the fact nobody's providing clinical therapy, but in terms of resources and problem solving and parallel goal setting and those kinds of things. And that time period can be up to 6 months, and it's usually longer than 3 months.
I don't know if there's anything more to add to that portion of the content.
Yeah, well, the only thing I want to bring forward is that, again, we were granted the opportunity of working with the EDC and with the Johnny Hopkins Foundation with, at that time, the Executive Director of Elder Services, Alice Bonner. She did a survey with the area hospital, with the mass hospitals, to find out about our reporting of of abuse, neglect, and mistreatment. And based on the information we submitted, we were selected as a representative from Massachusetts to actually participate in this program. We're one of, Carol-Lynne, correct me if I'm wrong, 7 hospitals nationally?
I believe it's down to 6, Barbara.
Okay. So nationally, and we're considered the most progressive. So I'm going, phew, hey, you know, we do things well out here in the most northern North Quabbin area of Massachusetts. It all doesn't have to be done on that side of 495. And I think that's a huge compliment, because people often think that bigger's better, and you do things, you get more results with the bigger organizations. I think one of the biggest attributes that we have in our region is the fact that we can network and collaborate on a one-to-one basis and affect change on a case-by-case basis. And so again, I just want to bring in the community supports are key and essential to the success for LifePath Protective Services and our work in elder abuse and mistreatment.
Thank you. Josefa, are you asking for Barbara to determine or share with us what EDC stands for? Yeah, so Barbara, EDC, will you just clarify that, please? Or close?
Carolyn, can you help me?
Oh, sorry.
I'll pull it up and I'll put it in our link. I'll go get it now.
Okay.
Thank you. So I think that for this next section, you know, we're asking for you to describe your relationship between, you know, your program and community-based resources like protective services, which you've done a little bit of, but how do you also make the distinction between when to file a report of concern or refer to those other kinds of resources? Who would like to start on those?
I'm going to turn it over to Carolyn. Frontline.
Yeah. I think that that's changed in the past 9 months. I think that 9 months ago when we started this journey that we're on, that we never, or very rarely, the only time we ever made referrals was in the violent history, like I told you about. My granddaughter's stealing my meds, my grandson's taking all my money. If I don't do this, they're not going to do that. And so it's kind of a threatening situation. I think in 9 months that we have changed that. And that we now feel that we no longer, it's not a problem. I don't want to say problem, but it's not punitive to make the referral. I think that in our heads as nurses and even people in the community, if you said the word DCF, everybody's like, oh no, you don't want to talk to them. Well, that's not true. They can help you. So that's the same thing that we have to realize with APS, is we're not making a referral to be punitive. We're making a referral to help that elder continue in the lifestyle that they want to continue in. And if they need help getting rides to the doctor, or if they need help getting food into their home, or if they need a home health aide to come in and help bathe them, that this is a way that we can get them hooked to services and without it being completely punitive. Somebody comes into the home, sees how they're doing, and can assist if the elder will allow us. I will tell you, that is the most frustrating thing to my nurses, to all of us. We are nurses in the ED. We see a problem, we want to fix it, we tie it up in a bowl, we send it away. We can't do that in this situation, because if the elder says, no, you can't tie that bow, then we can't tie that bow. So that is very, very frustrating. But that is what, that we have found in that. So how do I know who needs it and who doesn't? I don't. That's kind of why I rely on Dean. I'm going to fill this out. I see a situation. I'm not sure if they need it, but let's file it. Or if we're keeping a patient, so anybody that we're sending home, most of the time we will file. If somebody's staying into the hospital, most of the staff here will just refer to social services, but I will collaborate with social services at times and say, listen, I think that we need to file on this even though they're admitted. And sometimes I'll even collaborate on patients that they didn't file on that we sent home. And I'll say, something's not right here. We didn't file, we might have, should have. So I think that we should. And Kathy Bonds, who is a social worker down here in the emergency room, does outpatient, will assist me with that and will help me with filing. It is a sixth sense that we have. Like I said, I've been doing this for 35 years. I see the difference. And I think a lot of the nurses here too, ER nurses, we can spot a lot of things across the room. And a lot of times we can see that this is a problem, and we just know that it's a problem without any black and white picture, if that makes any sense.
I've seen more collaboration. And again, I think, Carolyn and I have both been here a long time, and things aren't as black and white as we thought they were. And, just because you're protective services doesn't mean you go into the home and rip the elder out and save them from the world. Oh my God, let's ask the elder first from what's going on and what would they like to do. So when we're talking about in the hospital atmosphere, we're always asking about patient choice. Well, it's about resident control and choice as well. And I think in the 9 months that we've been working more collaboratively with this project, I think both Carolyn and I can say that we've kind of like loosened up that harness that we had around us, that black and white piece, to really realize that there is no black and white, there is gray. And with some family dynamics, they've always had these dynamics, and we're not going to be fixing these dynamics. And who am I to say that this is not good for this person? We've got to ask the individual themselves. So this has really taken a deep process with us as care providers to really walk in that patient's shoes and see what they want to do and how they want to live. And if we can enhance those services with partnering with LifePath and other elder protective service organizations, we can enhance the quality of life for our elders, and that's what we need to do.
Anything more before we move on, or any questions from participants? I would like to share that Barbara put in the chat, Education Development Center is that EDC reference.
I just want to call out too, we have Debbie Lang who's joined us, who's been our liaison really for the Elder Protective Mistreatment Program. Debbie, I don't know if you have just a couple minutes just to kind of interject. I told them that you think we're great.
She put in the chat that she was having audio trouble, so she was going to log off and log back on.
Okay.
I do want to tell you one thing, sorry, that we as administration are so excited about how well that we have done and how well everything has gone, that through EDC, we have met, we are done with the study as far as seeing patients and sending them patient data. We are not stopping. We are not taking those questions away out of the EMR of the patient's record. We're still going to continue to ask all the patients 60 and over the same thing, and we're going to continue to screen these patients. So even though through EDC we no longer have to, we have seen how great that everything we have done in the last 9 months is helping our community, and we are going to continue even though we don't have to, which I know makes EDC very excited, but it makes me excited too because I feel like we're giving our community what they need.
Thank you all. So it looks like we're going to move into a caregiver portion of the discussion with questions such as, what do you want people to know about the challenges you see in caregiver relationships? What do you want people to know about community-based response to caregiver concerns? What is a misconception about your program or roles that you'd like to clear up? What can be accomplished when we go together? What are the ways protective services can help people make big changes in their life that have been previously daunting, including accessing legal remedy, etc. So who'd like to start on this section?
Do we want to wait just a minute, Debbie, if you wanted to share, because before we move on?
Sure.
Oh, you're muted, Debbie.
Hi, everyone. I'm so sorry. I was having trouble getting in. And to be honest, I'm just jumping in. My audio wasn't working, so I had to come back in and out. I'm not exactly sure where you're at and how you might, what I could add to whatever Barbara and Carolyn said is probably way more than I might need to add. But
Debbie, I think the whole project, what did you get out of that with our participation?
Oh my gosh. Well, we call Heywood superstars for many reasons, because, I mean, from the very beginning that we connected with them, they helped us to develop this care model around how can EDs help to identify elders who are being mistreated or at risk for that. So at the get-go, they had lots to share, and from a very, from a real community-oriented level. So, you know, they told us all about who they are, and they demonstrated it, you know, as well. And then when they agreed to be one of the test sites, and as I would imagine Carolyn and Barbara have been talking to you about what they've actually been doing over the last 9 months, you know, again, jumping in, getting staff trained, implementing this brand new set of screening questions and protocols in their ED, and really coming forward with rich data about the ability to identify elders at risk. And I think that what I've certainly heard from them is that how much they're learning and how much they're teaching all of us about how that can happen. And one of the great things also about having worked with them is the degree to which, from a hospital perspective, they could talk about their connection in the community. You know, it wasn't, I mean, Joan and Carol-Lynne have, you know, taken on their shoulders actually implementing this within the walls of the ED, but they're always very clear about how important it was to consider what's going to happen to elders when they leave the department, the hospital, because they said very clearly, you know, we can't fix that problem. We can identify it, and then we discharge patients, and that's actually the real crux that we're trying to continue to address. But Barbara and Carolyn and Joan have been very upfront about, you know, what's happening in the Gardner area, in the North Central area, so sort of introducing us to your world, and we continue to consider how can we keep elders safe. So it's one thing to identify, because the initial research is showing that there really is a pretty strong prevalence of mistreatment or for elders or those who are really at risk. I mean, somewhere, you know, in the 10% ballpark, which might sound like that's a relatively huge amount of people, you know, when you think about elders across the spectrum. So we have a lot of work to do to keep elders safe. Hope I didn't go on too long and try to, you know, give my spin on it. I could talk a lot more about how great it's been working with Heywood and getting to know and starting to be part of these conversations outside of the hospital walls. So thank you.
Debbie, thank you for jumping in there and doing a great job and being very animated and excited about that work. Barbara said you're a fan of theirs, so you definitely proved that. So I guess I'm being reminded by our tech support that if you'd like to change your view to be able to see more people, that you can change your gallery view up in the top right to see more of the participants, or at least the videos if you're interested in doing that. So moving on to the caregiver piece, again, about challenges to caregiver relationships and community-based response to caregiver concerns. Should I go through those again, or were you ready with a response, any of you?
I could start.
Great.
I think I'm going to start talking more generally, and then I had a few examples that I think are illustrative, but I don't want to get too in the weeds with it, because I really want to focus on the idea that, you know, pick up on some of these threads that have already been mentioned about adult protective services being a sort of hub that has a variety of places that can report in, and then as at least at LifePath is a sort of concentration of resources and talent and devotion to the work that can then support older adults in the community. And so I really want to focus on the ways that, like we all said to each other already, that is not punitive. I think we'll have the chance to talk about some of the major misconceptions about the work that we do. And I'll try to answer this first question. What do I want people to know about the challenges we see in caregiver relationships in that broad way, and then maybe share some of these examples. So I think that when people are concerned about protective services being sort of adjacent to or an arm of law enforcement, that when they're thinking about caregiving and neglect and caregiver problems, they potentially see our role as investigating the wrongdoing rather than taking the opportunities offered by this relationship to see, like, what's missing, what are the things we know about why that's missing, and how can we fill in those gaps. And certainly, you know, Dean will talk a little bit about that later on. Certainly there are times that the results of neglectful behaviors do qualify as abuse of an older adult, and there are steps we need to take in response to that. But primarily what we see is that caregiving is super complicated, and that and caregiving relationships often are embedded in long histories, family or otherwise, and that the goal is that both the person providing care and the person receiving care are getting something from that relationship, that it's not one-sided, and that we know that we approach our work with a full awareness of the ways that those care relationships change over time and change according to people's capacity. I think a lot about when we come into contact with an adult child who's caring for a parent, and the ways that all of their collective experience of the parent previously caring for the child are showing up, you know, in that room and in that relationship. And we also have a lot of cases where the dynamics of a marriage, of a partnership, of an intimate partnership have been changing, and we see like a crisis point where that relationship is shifting, and the way that they're caring for each other is shifting in their 4th, 5th, 6th decade of being married or being in an intimate partnership, and the way that caregiving roles and needs can change the dynamics of that relationship. And so I guess what I want to say is that our program and the people that I work with in this program are looking at all of those things and have an open and curious mind about how all those dynamics are playing out together, and are not just going in to look for like who was supposed to do the shower that didn't do the shower, and like who was supposed to cook the meal and didn't cook the meal, right? That those are sometimes, often, really important needs that we have to figure out how to get met. And when we're thinking about like what does caregiving mean for this person and their relationships on the whole, we're not focused on the like who did what when or who didn't do what when, but rather those broader dynamics and how we can get those needs met. I think I'm not going to share the examples right now because I think they're just more specific than is helpful to talk about at this point, but maybe they'll come up later. I think I was supposed to do the next. Carol, should I keep going in this section, or should I take a minute and see if Barbara or Carol-Lynne want to respond to this question about challenges in caregiver relationships?
Maybe we ask about challenges across the board. Carol-Lynne or Barbara?
I think you articulated the dynamics that we're seeing. And again, I think Josefa, talking about as we age, the various roles that a caregiver plays, from being the one taken care of to being the caregiver, the stress that plays upon people. And if you're adding chronic diseases on top of that, or dementia, or an Alzheimer's mental status type of situation, that just adds more weight to the severity of some of these families. And it's almost like, who do you take care of first? Yeah, and you've got to try to take care of them together. And oftentimes, Carolyn, I know sometimes we'll have a patient come in the emergency room and we're offering whether or not we should put another bed in the room to go along with the significant other that's come into the hospital.
Yeah, it's hard. And sometimes a case comes to my head right away where we had a situation that we thought that the patient that needed the care, that had the worst dementia, was the wife, and it was the husband. And that really is a challenge. It's a big challenge. And you see it, especially if we separate them for some reason, if one gets admitted to the hospital. And that's a big challenge that it's really, I think it's hard to identify. It's not easily seen. We stumble upon it by mistake a lot of times. And I think that's, and they hide it from their families too. Couples, people, life partners, they've been taking care of each other for so long that the family, they cover up each other's problems, and the families don't even realize it. And then we have the cases of the children who have had this independent parent for their whole lives, and then all of a sudden, quickly they realize that the parent doesn't even remember to get up and shower in the morning. And those are the people that I'm asking Dean and Josefa to help with, to help those children who are trying to help their parents that do not know how to get any services. They do not know what's there. And that's where they're the experts.
I think that's those are the more frequent cases that we've seen during the pandemic, is the children that, you know, because of the physical and social isolation, people are really, when they finally come into the hospital, the children are surprised. And shocked in some cases. So, you know, as much contact with those community providers, you know, it's key. And I'm glad that LifePath has also gone to using the iPads, you know, as just some form of communication with the seniors that are really isolated out there.
Anything more on challenges or any questions about that from participants? So we can move on to maybe some misconceptions, or what can we accomplish when we go together? Maybe combating those misconceptions and helping each other, and how does that work moving forward in kind of a different time and place than we've ever been in before?
Sure, I'll start this one, but I do want to say that in terms of LifePath's Adult Protective Services program and our community-based response, that that certainly there are things particularly relevant to our like rural location and the resources that we have that are challenges and that we talk about amongst each other, that we, you know, like transportation and access to internet and how far away a grocery store is, right? Like all of those structural issues are there, and I am not trying to be like Pollyanna about them. But what I do want to say is that I think I feel incredibly lucky, and I think my colleagues feel really lucky to be working within LifePath, because there are just so many programs and so many options for programs. And I do, the question that is posed that I'm trying to answer is what I want people to know about community-based response to caregiver concerns. And what I want you all to know is that we're committed to thinking about that really creatively and to using all of the resources we have at our disposal, both within LifePath and within communities and councils on aging and neighborhood groups and faith-based communities and friendships and all of those kinds of things. And I'll move on to what can be accomplished when we go together. And I do think that this has been impacted by COVID precautions in a really serious way. However, this, just a short anecdote, is that when I was thinking about this going together idea, it's because I was on a planning call where a few of us were talking about what's happening when a system gets changed in real time, much like Barbara and Carol-Lynne are talking about this opportunity with EDC and how their system is getting changed in real time and what that afforded them. And I was listening to this anecdote of a person that works with youth talking about trying to figure out what exactly was wrong about this program that the youth was supposed to be attending. And they couldn't quite figure it out, and they trusted this person, and they knew that if she wasn't going, there was something wrong. And they knew that if she couldn't articulate what was wrong, that they needed more information. And she said to her, let's just go together. Right? So she went with her to this program, and they figured out what the deal was, and there was something very clearly wrong, and they figured it out together. But the times that we go together in protective services are things like housing court issues when there's evictions, things like requesting restraining or protective orders when there's intimate partner or other family violence. Sometimes when we go together is when a person knows they're contending with the idea that they need more care at home, and they're confronting the ways that they're addressing how that equals to them a loss of independence or what it means about their aging process, and they're really freaked out about it. And the protective services worker can go together with them to that intake meeting with the home care provider, so that the person that they've already built a relationship with, that they've shared these fears with, is there with them while they're doing that intake. And I think in general, what we accomplish when we go together is that the older adult we're working with isn't met with, I think, the really common trope of, why are you making a bad choice? Or like, why won't you just do this thing to address the risk or to take care of yourself? Or the way we talk sometimes with each other, they just won't do it, or they're resistant, or they're non-compliant, right? When you go together with them, that's part of our person-centered approach, right? That the life decisions are happening to the older adult. It's not happening to us, even though, you know, I think sometimes people working with older adults communicate with each other like if they just accepted all the interventions, everything would be great, right? That all those issues would be solved. And so I think that going together provides like a much more respectful approach to making those kinds of changes.
Anyone else want to comment on going together, your own view of what that looks like or what that means?
I do want to say, you know, even going together with an elder, that this can lead into the misconceptions about protective services, is that, you know, we can, you know, do as Josefa says, where we go together and trying to address this concern. But elders, you know, can make their own choices and do make their own choices. And sometimes we don't end up going together and they decide to make their own decisions, and they will live with risk and there'll be consequences, and protective services might not be effective in making them make better choices. And I think that's a misconception that people have about protective services, is that we can do things to protect somebody, you know, even against their own will. We're not DCF. And so, you know, one of our greatest things we believe in protective services is the right to self-determination, which is respecting that person's wishes and going together, as Josefa would say. And that is one of our greatest strengths, is that belief and that philosophy, but it can also be the reason why sometimes things don't change for a particular person. And that's why things don't always change the way professionals and community people think they should change, and that they want to know why things have not changed for the better. I just wanted to add that piece.
So we're gonna, I'm just gonna do a quick time check. We're just about at 3 o'clock. We do have another question here, and around 3:10 or so, we will be opening it up to question and A and that breakout room opportunity. But this last question on the docket here is, what are the ways protective services can help people make big changes in their life that have been previously daunting?
Big changes. That's a good question. I mean, I don't know if we ever make huge changes. Sometimes we do. Typically, we can make incremental changes with somebody who's willing to accept protective services. But again, I want to emphasize that we work with the client, not around the client. Again, which can always be a barrier to getting them to make changes. And we go at their own pace. We don't rush in. We don't come up with a plan and just say, here, this is what can fix your problem. We make suggestions. We might push a little when the elder needs pushing. We might back off when they need us to back off a little bit. We can go as slow or as aggressive as the client needs or wants. You know, obviously, if someone is being seriously abused or seriously neglected, we do have the ability to act a little more aggressively if that is what the elder wants. You know, we can use legal resources. We have the ability to go to court to get protective orders or put in services if somebody lacks capacity and somebody is preventing it. But typically that's only in extreme cases. But we, again, so these big changes, even incremental changes, it's really about slowing down, working with the elder, and showing them the respect that they get to drive the bus and they get to make their own choices. I don't know if Josefa would like to add to any of that.
I just had one thought. I think one of the ways that we help people make big changes is by not having our own agenda and by doing just what you said, because it's very common that we work with someone a few times, sometimes more than a few times, over the course of a 2-year period or a 5-year period. And I don't think that the North Quabbin and Franklin County are unique in this, but certainly we've been experiencing the impacts of substance use disorder, and certainly there's a lot of poverty where we live. And so I think that the ways that that impacts family dynamics and is related to abusive dynamics that we see in some cases, when those often take a really long time to move the needle on. And so one of the ways that we can do that is by not forcing and by being person-centered and allowing for, both the dignity of risk and incremental change that's not on anybody else's timeline. And so if a person has that experience with us once, 6 months later, when there's a little something else going on, and 6 months after that, when there's a little something else going on, then they have built a relationship of trust with us when they're ready to make a big change, like having someone that lives with them leave their home, or moving from living in their own apartment to something with more support, those kinds of things. I think we're better positioned to do those big changes because of the way that we allow for progress to be for it to not be linear.
I think, Josefa, one of the things that struck me about what you said is the trust piece. And, how do you foster that, or, where do you find it? Is it surprising to you? Do you get pushback? I'm sure, you are faced with all kinds of unique situations every time you pick up the phone or visit with someone. But I think that trust piece is a huge part of what I would imagine what you're working with there or trying to secure. So I don't know if there's anything more you might want to say about that.
Well, I don't want to put her on the spot, but I wonder if Sue has anything she wants to say in response to that. She's the only one on this call right now that's working in the field with older adults doing PS work right now. Is that fair, Sue? Do you have anything?
All I can say is that it was interesting. I was wondering if you were going to answer that, because you could, because you were a protective service worker. But I would say that's probably one of the most important things that I do, is establishing a relationship with an elder. And if I can't do that from the very get-go, my chances of making any kind of a successful interaction or is not going to happen. So I take that very seriously when I go out to meet with somebody for the very first time, or even picking up the phone, the very first initial phone call. How I make that call, how I present myself, how I introduce the program is really important. And I need to kind of understand who it is that I'm calling, and to be very mindful of how much I share. So it's a game, but I do believe establishing that a relationship is probably one of the most important things that I do in my job.
And, I would say from knowing Sue's work that the patience and compassion that she brings to that relationship building is what allows for her to do that. There are certainly times when a person doing her job, where you could understand if they were like, I gotta get in, I gotta get out, I gotta, like everybody's busy, right? And so the patience and care with which Sue approaches those relationships, I think, means that she's incredibly successful building trusting relationships with really, really challenging situations. Like just this morning, she was telling me about a case where everybody's just not sure like what's happening clinically in terms of infection. We know that there's a history of sort of complicated mental health challenges. And so Sue spent the morning sitting and talking with this person without mentioning a lot of the details of the concerns in the report, because that wasn't important for that first meeting. What was important was to have some contact and to build a relationship, and it takes a lot of skill and discipline and patience to move at that pace.
It's a tight team over here, as I'm sure it is at Athol Heywood too. That's great. So I don't know if there's anything more that anyone else wants to share before we kind of turn it over to a more proper question and answer period, and perhaps that breakout room with Sue, who you just heard from. Anything more?
Carol,
So
may I just say that, you know, it truly is a privilege to be able to work with elder services the way we've been working. And I'm extremely proud of the relationship building that we have had with the LifePath group. So much so that we drafted Josepha for our medical ethics committee on the Athol campus. So, you know, we are trying to get multiple layers of the education throughout the healthcare system without it saying, oh, we have a protective service person here. It's those subtle influences into our system to help us to work better. So again, thank you for the opportunity of us being able to present with you today. And I'm extremely proud of the hard work that we've all been doing. And we've got lots more to do.
I wanted to second that too, Barbara. I think it's been great the past year or two since you've had that program and we're working more collaboratively together. I feel like we can call each other up and just say, here's what I have, what do you think? We talk once in a while, and I think it's been a great boon to both of our programs.
So with that, if there are any questions or observations or thoughts from participants on anything that you've heard over this last hour or so that may help you with your own work in these areas, please feel free to unmute and ask a question. And while you may be finding your unmute button, if there's anyone who may want to have a little session with Sue, 10 minutes or so, maybe Andy, if we could have them chat to LifePath Tech Support to request a little bit of time with Sue. Does that work?
Perfect.
And there's LifePath Tech Support right there. But don't be shy. If there's anything that you think LifePath may be able to help as far as a resource or questions about resources that we might have on hand or available or through the community, if you have questions about that, if you have questions about, more specific questions about the program at Athol Hospital, Heywood Healthcare, you know, both sides of the coin, you see that they're working very collaboratively together, and that maybe there's something they missed in telling us or something that you're curious about, something that may help someone you work with.
Dean and I are also happy to be really specific if anybody has questions about adult protective services, like program stuff or when and how and who to report, that kind of thing. You can certainly use this time for that if you have any of those questions.
And we like feedback and criticism too. So it doesn't have to be positive. It could be just, what are you guys doing?
Dean, Dean, or anyone, how about you put your email in the chat box, Dean? Get all the feedback you want, right?
There we go.
I do see that LifePath Executive Director Barbara Bodson has typed in the chat, many thanks to the Heywood staff and the LifePath staff for fostering these strong and productive relationships which benefit those we serve. So thank you, everyone. Oh, Debbie, did you have your hand up?
I was clapping for
Oh, okay.
That's what you meant. Yeah, applauding all the work that's being done. And I'm learning more and more about PS. And I do want to give a shout out to Dean because he has been part of the conversations we've had as we've been testing the model, including the development of an actual toolkit that would help strengthen the connection between hospitals and EDs and APS and the community in general. So like I was saying, that when elders are discharged and there are real concerns about their safety, we especially want to strengthen those connections. So I'm all ears to learn more about APS, and I'm actually actively working on this, what we call a toolkit, and in part, I'm very interested in having it include some training or resources that can really speak to making those connections and strengthening those relationships. And we're learning from Heywood, but this is a model that we're wanting to disseminate across the country. So I like to be more fly on the wall now.
Thanks, Debbie.
Thank you, Dean.
Well, I don't want to cut anyone short, but I know everyone is busy, and I don't feel like we need to, you know, hang with everyone here if there aren't any more questions. But, you know, please feel free to reach out to us at LifePath and, you know, ask those questions. You know, you have the offer, or to Athol Hospital, Heywood Healthcare. You know, we have the offer of, you know, having that conversation if there's anything that is of concern to you, or that you're just not sure about. You know, placing a call to us is something that we're definitely open to and certainly want to be helpful with. Any last thoughts from our panel or otherwise?
We have a lot of information in the chat about how to make a report. I'm just about to add in how to ask for a consultation. Is there anybody who's just on the phone that can't see the chat? So, like, is it helpful to say it out loud?
I think that's a good idea, Josefa.
Okay. So I'm not going to say out loud the web address to file a report online. It's a little bit cumbersome, but the phone number is 1-800-922-2275. And if you'd like to have a more informal consultation with anybody from the Protective Services staff, you can call us at LifePath 413-773-5555. And if you ask for a Protective Services supervisor, you'll get someone that can help you.
And if you just Google report elder abuse in Massachusetts, it'll give you the link. It'll be the first thing that pops up.
And the other thing that I just put in the chat is that original registration form that we had out there for this event, and we can share with you this recording and any of this information in a follow-up email. If you want to click on that link and register yourself so that we can have your contact information to be able to send that to you after the fact, we'd be happy to do that. Okay, well, Barbara, Carol-Lynne, Dean, Josefa, Sue, and Debbie, thank you all for participating in the ways that you did for this group today, Caring in Community. We really appreciate all the work that you're doing in front of and behind the scenes for local elders and their caregivers and their families. It's so important. Thank you so very much. And we wish everyone a really wonderful holiday season and a bright new year. And thank you for being with us today. Take care, everyone.
Thank you so much.